Can you hear Oleg properly?
You might need to do that a few times. You might just need to do that a few times.
Okay, Oleg, you're breaking up a little bit, but I'm just going to start the presentation, and you guys just send me something through on the chat if you're having difficulty hearing me. I'm just going to mute everybody else.
Now your voice is...
Sorry, I've just muted whoever started to talk then. My voice is okay. Good. Okay. So thank you for joining us today. Like I say, if there are any problems, just send something down on the chat, and I'll try my best to answer it. And if I'm not seeing you, pop your hand up and I'll try and answer it that way. And if I'm still not seeing you, just shout over the top of me, not a problem. Okay, so it's a really big topic, pacing in congenital heart disease. I've tried to do a brief summary of different aspects of it, the reasons why we try and come to the decisions that we do, and the things that we're thinking about on our way to making that decision. We can't really talk about pacing in congenital heart disease without a little bit of an overview of what pacing is and how it works. I will try really hard not to bore everybody, and if everybody can just do the best to keep the microphones muted whilst I'm talking, and then just shout out if you need to say anything. Okay, so with regards to the history of pacemakers, it's actually really varied depending on where you read. So I just decided to cherry pick the bits that sounded best in the presentation. There's all sorts of stuff talking about the use of putting electrical currents through needles that are being put into the heart in the 1899, and how that couldn't possibly work long term because you'd end up putting lots and lots of holes inside the heart. So I'm pleased that they realised that early on. That the main progress, unfortunately for cardiologists, seems to have been made by surgeons. So following on from Hyman's discussion about an artificial pacemaker, where essentially he was shot down by his colleagues and people saying that he was creating an infernal machine that interferes with the will of God, and then everybody basically blackballed him and he wasn't allowed to create his machine that he'd thought of. In the 50s, surgeon Walton Lillihei talked about using a battery-powered device, and that was because, although there'd been progress since 1899, in Minnesota at the time they were doing apparently over 300 open heart operations on young adults and children with congenital defects. And he had a myocardial wire for post-op pacing that used a machine to convert the alternating current into DC current. And unfortunately, on Halloween 1957, whilst he was in the middle of a procedure on a baby, there was a 3-hour power cut in Minneapolis, and obviously the baby died as part of the complications of that power cut. So the very next day, the surgeon came in and spoke to one of the engineers in the hospital, Earl Backen, and talked about building a battery-powered device to prevent future tragedies. And the engineer had seen something in Popular Electronics that month that used transistors to make an electronic metronome. And instead of basically the beats coming out through a speaker, it was the beats were coming out on a wire that pulsed the heart. And so he formed a company and named it Medtronic. So in the 60s, then we moved on from having to push these huge trolleys around pacing the heart from an external machine, and then onto smaller machines that you could wrap around your neck and go for a walk around the ward, into an entirely internal pacing system. And things have progressed from there. Because it's a brief overview, I'm just going to pretend that you all know about the new pacing boxes since the 1960s. So what is a pacing system? So this is an implantable pacemaker circuit. So you've got your generator that's connected via leads to the heart. And inside the generator, you've got the battery, the circuitry that allows programming of the device, and then the connectors that allows the leads to join the IPG to the heart. The leads that are shown are bipolar leads because the cathode at the end where the negative electrode is and the anode, which is the ring where the positive electrode is, are both on that wire, and therefore the circuit is small and localized to that with very little body tissue in between the two. This is a unipolar system, and as you can see, there's just the cathode at the far end where you try and depolarize the heart and myocardium, and then the circuit is completed by going back through the body tissue to the IPG, which is the anode. And that's why we worry about diathermy, because wherever you are in that region, you're going to cause interference in the circuit and make the pacemaker believe, in inverted commas, that there's electrical activity and therefore it doesn't need to do anything at all. Again, whistle-stop tour of what pacing is. So the most simplistic pacing version you can have is a single chamber device, whether that's VVI or AAI. And the leads that you can have can be unipolar or bipolar. So the unipolar leads are smaller diameter, have a big pacing spike on the ECG if you've seen one, but can cause muscle stimulation and are also pretty rubbish at sensing due to myopotentials being picked up or EMR. Bipolar leads are much better at sensing with less issues with that, and usually their thresholds are lower too. So I'm just getting a message from a different group. I thought we had a question. So moving on to the coding, we've got the usual codes that people will have heard of: DDD, VVI, AAI, and then the rate response modes. So the same modes, but with rate response switched on. And when you see the initials for pacing, first chamber, the first letter is the chamber that is paced. Second is that is sensed, and the third is what you do to that sensed beat. As a result of that sense beat, with the fourth being rate response or no rate response. We generally tend not to use the fifth multi-site pacing letter, but obviously A is atrium, V is ventricle, and D is both. So types of leads that we have. So we've got a varied audience, so we use both endocardial leads, transvenous leads. So you can see the passive leads with the tines, they're the little spikes coming out of the transvenous leads, or the active leads, which has got the screwy coil you come with a little mechanism that you use at the other end of the lead to release the screw out of the lead and into the heart. And they're much better for extracting because the profile's smaller, but it's still secure. So when you want to come to extract it, you can unravel the screw and it comes back inside usually, as opposed to the tines that are basically have been grown around by the myocardium, and when you pull a lot of other things with it. And then there's the epicardial leads, as you can see there. There's the fishhook type or the screw type or the buttons. And then I promise not to keep going on about these aspects of pacing, but there is a reasonable amount of knowledge needed for it if you're going to be involved in any aspects of patients with pacing. There's a few more slides as extra at the end if we feel like we need to do a little bit more on this, but as a brief summary, voltage is essentially the force of the current that we use to get the energy to do what we need it to do, and the current is the flow of that electricity into the myocardial cells to get the heart to beat. And so you can have lots or minimal, and then the impedance is the resistance to flow. So you can have no resistance or normal resistance or too much resistance. And we use these to help to optimize our pacing strategies and to optimize the care of the patient. Okay, so that's a brief summary of pacing and the different aspects of the components of the pacing systems. If there's any quick questions about that, just give me a hands up now. Okay, so we'll move on to some of the things that we come across in congenital heart disease. So there are consensus guidelines on when to use pacing in congenital heart disease in pediatric patients. Obviously, the evidence base is smaller than in adult pacing consensus guidelines. There's a few more 2A indications, and there is generally an awful lot of head scratching around those about when the right time to do it and when the right time isn't, even though it's a 2A. But in terms of the class 1 indications, they make my life a lot easier. So symptomatic sinus node dysfunction during age inappropriate bradycardia. So in paediatrics, we try and veer away from this because it's quite difficult to find out what these symptoms are in some of our kiddies. So I spend a long time in clinic trying to figure out what the symptoms are that these children are having who do have lower heart rates. But often we end up just seeing how things go on regular non-invasive monitoring if there's no suspicion of anything more significant happening. Bradycardia with block makes me think a little bit harder about when to jump in and do something, especially if there are ventricular arrhythmias. So the lower your heart rate is, the more likely you are to have dangerous arrhythmias, or even non-dangerous arrhythmias, but in the context of congenital heart disease can cause hemodynamic instability and become dangerous. Advanced second or third degree AV block with symptomatic bradycardia, ventricular dysfunction or low cardiac output. So this is in any congenital heart disease patients. But also there's those that have got structurally normal hearts with congenital complete heart block that have got poor function or complex ventricular ectopy or a broad escape rhythm, indicating that it's an unreliable focus for the escape that may end up having pacemaker as a result of those signs too. We're going to come on and talk in a little bit more detail about post-operative high-grade second or third degree block that's not expected to resolve or persist greater or equal to 7 days after cardiac surgery. And we're going to talk about each of those aspects. And then we've talked about congenital block already. I'm not going to go into details about the class 2A. You can see that what they are there. Usually, if you come up with a question as to whether your patient should have one of these, to me, I'll generally give you a non-committal answer until I've gone through the patient record myself, because there's usually lots of other considerations rather than just accepting that it's a 2A indication and jumping on with it. Some of those issues that I'll be contemplating, I'm going to talk about now too. So if you are going to go down the road of epicardial pacing, you want to know what the reasons for choosing epicardial over endocardial pacing is, and if you agree that we've met a class 1 indication, then you've got your when you should do it, because it should be when you meet your class 1 indication. And then it's a question of what other things you need to think about once you've chosen to use epicardial pacing. And epicardial pacing leads are not without risk. You can see that there are some significant risks there listed. We do reasonably regular chest x-rays in pacing clinic for our epicardial devices, looking for potential for strangulation and causing any of those side effects there. We do an annual echo to confirm that there's no issues with function, dilatation, or indeed any pacing related cardiomyopathy. And then obviously there's the short and longer term issues, including the need for redo procedures because of poor battery life or poor lead life, depending on whether they're fractures or requiring high pacing thresholds, draining the battery. Sorry, my computer's just trying to restart. Just tell it to go away. Okay, so some patient-specific factors that come into decision-making with each of our patients. So the size does make a difference. If the children are less than 20 kilos, there is definitely literature out there of teams who've decided that the right thing to do was to try and put in an endocardial system in someone who's less than 20 kilos. We've done it here occasionally, but usually there are very, very good reasons not to put an epicardial lead in. But generally the consensus is if they're less than 20, you should be putting an epicardial lead in. And that's basically because it's a real pain to put an endocardial one in the smaller than 20 kilos. The sheaths are usually bigger than the vessels themselves. The lead going into those sheaths usually means that you're going to lose that vein almost immediately, or certainly as a subacute loss afterwards. There's a few other reasons that we can talk about at the end too. Between 20 and 30 kilos, it's kind of an institutional variation. So depending on the experience of the unit, there'll be some times where you put them in at 20 kilos and sometimes you would wait until the 30. And again, not just institutional variation, but patient variation too. Again, talking about loss of vessels, because these children are going to need lifelong pacing almost certainly, and if you lose one of the big vessels on the left side immediately, you've only got one more vessel to choose from on the right, and then you're in a position where you're going to have to do a lot of rehabilitation work to try and get back down through those vessels, with a lot of risk entailed in it. If they're over than 30 kilos, there's certain reasons why you would still go for epicardial. Some of the main ones are if you've got a very small subclavian vein because of a persistent left SVC, or if they've had previous cardiac surgery that suggests that you can have issues with stenosis in the veins, for example, when you've baffled through with partially anomalous pulmonary venous drainage leading to kinks around where the SVC is, or if there's recurrent thrombosis and you don't want to increase their risk any further. We've talked a little bit about anatomy when we've talked about size, but if you are considering endocardial versus epicardial for the patient, you need to know everything about the patient's anatomy, as well as their current anatomy post any procedures. And sometimes you need further investigation in CT, MR, or even catheter diagnostic angios to look for potential complicating factors on your way to placing this pacing system. And there's concern if there is long segment occlusion or significant thrombosis that actually endocardial systems with leads should not really be being used. If there's been the option of going for endocardial pacing, you can try and go in at the same time as an interventionist, or ask the interventionist to go in first and do balloon dilatation and stent placement. But again, you should probably have a really good contraindication for epicardial pacing if you're in these sorts of positions. Single ventricle patients, again, we have used endocardial systems in single ventricle patients. The problem is that with an extracardiac fontan, there's no transvenous route to the endocardium. If you've got a fenestration, you put in a lead through that fenestration, you've got the risk of thrombus both in the systemic circuit on the inside of the atrium and in the fontan side of things, where any thrombus would go on to cause increased pulmonary pressures with recurrent PEs. And that's the issue with using endocardial leads in the lateral tunnel fontans, leading to the same sorts of high pulmonary pressure issues. And with biventricular pacing, we've talked in inverted commas in a single ventricle patient, we know that paced single ventricle patients do very poorly. And sometimes we think or suspect that it's because of the poor paced function. And so people have attempted to place leads on both the left side of the systemic pumping chamber and on the right side of the same chamber, and tried to synchronize it intraoperatively with TOE to show the best cardiac output based on the positioning of those leads, or indeed on the QRS duration, something which I think is going to need an awful lot of patience and skill from the team in theatre to be able to get just right to warrant making a regular occurrence of it. There are obvious reasons why, if you've got a right to left shunt, that you should avoid putting endocardial systems in. If there is a right to left shunt that is small and can be closed, that may be something you ask your interventional colleague to perform. Although again, if it's somewhere close to where the lead will be, there can be interference between the device and the lead. So you have to be cautious about how confident you are doing this sort of procedure. And then there is reasonable evidence to show, there is evidence to show you shouldn't be putting leads through mechanical valves. But if you've got bioprosthetic valves, there's a lot of concern that even with a bioprosthetic valve, you're going to stent open the tricuspid valve, for example, with your lead, and this will increase your risk of thrombus and valve stenosis. If you've got significant pulmonary regurgitation because of other right-sided lesions, you may have no working competent valve on the right side of the heart, and so lead yourself to further problems. And it's times like these, in these sorts of patients, that we consider, again, depending on the anatomy, whether there's a suitable coronary sinus that would allow you instead just to solely pace the left side of the heart with endocardial lead through the coronary sinus. So each of these are giving you ideas why there are lots of things to think about when we discuss putting a pacemaker in. So yes, they may have good reasons to have a pacemaker, but there's an awful lot to consider about what other things you're introducing by performing a pacing system implantation, and a lot of arguments to be had about what the optimum system will be. This is for the surgeons, really. There's a choice of epicardial lead, unipolar versus bipolar, and then there's choices between each of those also. As a cardiologist, as an electrophysiologist, I don't like unipolar leads because they give me an awful lot of headaches in terms of oversensing. So if you've got a patient that requires pacing and has no underlying rates, but you've got a unipolar lead on the ventricle, and the unipolar lead sees artifacts from muscle or electromagnetic disruption, the pacemaker will assume that that is ventricular depolarization and will not pace. So then you're faced with a situation where you've got somebody with no underlying escape rhythm and a pacing system that can't do what it's told to do because it keeps thinking it's seeing something it's not. The other aspect to unipolar pacing is that if it fractures, it fractures. If you're lucky with bipolar pacing, if one of them fractures, you've got the second chance to use the second coil as a unipolar device instead, so preventing further surgery to replace that lead. And that's something that we would always try if a patient presents to clinic with a fracture and a bipolar lead, but obviously don't have the opportunity to do in a unipolar one. Very occasionally, there's not a lot you can do about what the choice of lead is if you don't have a lot of real estate to place the lead on, or if there's a small patient that there's no room for the lead to be placed. You may just have to be forced into a unipolar situation, and we have to try and find a way of working around it. But again, that introduces different risks. We know that steroid-eluting leads, when they were brought out, that there was better readings on the longevity and thresholds, and therefore that generally seems to be the go-to lead now. And we know that there are different passive or active subtypes, but that we know that there are some corkscrew type active fixation epicardial leads that penetrate up to 3.5 millimeters, and especially if you're going to be using that on some kiddies' atria, you end up going through the wall of the chamber. And whilst you sometimes use that 3.5 millimeters to bypass the fibrosis on the outside of the heart if they've had recurrent surgeries previously, you'd rather not bypass the entire chamber and just be pacing inside the chamber without any contact with the wall at all. We know that in congenital heart disease you can have problems with high thresholds with epicardial leads, and it can be a real pain. And we know that it happens for many different reasons, including the fact that there's been previous surgery with diseased myocardium. And we need significant patience from the team in theatre to be able to move the lead around to get the best possible readings. And the reason that the pacing team would like to have the best readings are because of the optimization of the device. When we know that the indication for surgery with a pacing system is to save life or protect it, the secondary indication is also to treat the patient as effectively as possible, and that's why a limited or prudent use of mapping of the surface of the heart is useful with these leads, bearing in mind that once you touch a lead onto the heart surface, you start eluting steroid, and there's only a finite amount of steroid there. People have documented using an endocardial lead, opening up a hole in the chamber and having a purse string to tighten the lead inside the chamber when really struggling in epicardial situations. But to my knowledge, I don't think we've done this here before. At Alder Hey, we've got a epicardial pacing SOP. It's useful for the juniors to see that talk about. Some of it's just for the physiology side of things to ensure we've got all the right equipment in the right place at the right time. But also there's a summary of the manufacturer's guidance on placement of the epicardial lead, specific to the lead that we use most frequently here in Alder Hey, to enable us to get the best outcomes from the lead placement. Okay, so if there's any questions about epicardial pacing, please just pop your hand up. now we're going to move on to post-operative heart block and indications for pacing and when you should do it. Okay. So despite everybody's best efforts, there are still in major cardiac, congenital cardiac surgical centres as a risk of 1 to 3% with operations of complete heart block. And in the literature, the resolution of complete heart block is between 43 and 92% of patients, depending on what the study is, what the era is, and how many patients there are. But what's useful to take away from the presentation is that those who regained AV conduction within the first month post surgery, 81% of them did so by day 7, so 4/5 by day 7, and 97% of them by day 9. So usually by day 9, if you've not regained your full conduction, then you should be ready for your next procedure. So sorry, Bernie, I've just seen your question from the right to left shunting, but we will have a chat about it. So is it the reasons why you would choose an epicardial is because you wouldn't want to do endocardial with right to left shunt. Okay, so back to heart block. So there are some studies, quite a few studies, that reported 100% mortality of those who've had post-operative complete heart block. And therefore, there are consensus guidelines that suggest that if you have complete heart block 7 days post-operatively, it's a class 1 indication for a pacing system. To complicate things, there's a class 3 indication, so a contraindication virtually, of not putting a pacing system in if there's transient post-op block with return of normal conduction. So what does transient mean? Well, they don't define what transient is. We know that late recovery is well recognised. We can see late recovery, so after 14 days, in 10% of patients, and so it's in the literature you'll see in one study the median time was 41 days post-recovery, up to 113 days post-op, sorry. And in one case report there was spontaneous recovery 20 years post-surgery. And nobody's been able to identify the markers of when you should do something and when you shouldn't. And so this kind of area between 7 and 14 days has got a lot of uncertainty about it, because even if it returns after 7 to 10 days, is there any risk involved? And how long should you wait to decide? And if there's difficulties in negotiations with parents, what should you do? When should you plump for going ahead? So to answer that question, we need to talk about the late recurrence. And we know that in one study there was 114 patients that had a pacemaker implanted for complete heart block after congenital heart disease surgery. And in those 114 patients, there were two groups separated into those who had it found less than 30 days after the surgery or more than 30 days after the surgery. And in those that had complete heart block found more than 30 days after the surgery, there was 36% of those 114 patients, with an average finding of complete heart block 4.7 years after the surgery. And so we think that there's probably a group of these congenital heart disease patients that have their surgery and don't have any problems as a result of their surgery, but do go on to develop complete heart block as a result of the substrate of congenital heart disease that they've got. It makes it hard to decide what the kind of right information to take away from these studies is in terms of when to place a pacemaker and when not to. But the takeaway home for cardiologists is that there should be regular outpatient monitoring of all congenital heart disease patients for potential AV block, and that's why we do regular ECGs, hopefully. Probably the most startling or useful aspect in the literature about late recurrence and transient AV block is a study performed in tetralogy of Fallot patients, so 288 tetralogy of Fallot patients followed up over 28 years. And they compared 3 different groups. Those that developed so all of them, those that developed complete heart block that had resolved spontaneously by day 4, and there were 20 of those. There were 55 of those. Those that had transient complete heart block that resolved after day 3, and there were 20 of those. And then those that didn't have any transient AV block, and there were 196 of those. And when you see the group of patients where the complete heart block resolved less than 4 days, it's very similar sudden death rate to that group that never had any never had any complete heart block post-operatively. So we're saying that probably the risk of sudden death because of heart block in children who have return of conduction in less than 4 days is probably similar, whereas if it's more than 4 days, there will be an increased risk of sudden death. So now you've got a situation where you've got a guideline that says you should implant your pacemakers in those post-operatively who've got 7 or more days of conduction disturbance, but you've got a group in the middle where in between 4 and 7 days we're saying there's no class 1 indication to implant here, but you do still have a risk of sudden death that is higher than your peer group. So that's something to think about on the ward, and that's why we ask when patients come and step down onto the ward that on the problem list, if there's been transient AV block, it should be documented how many days there was AV block for post-operatively, so that the cardiologist can bear that in mind when looking at serial ECGs through the follow-up through the rest of their lives to help stratify their risk. Okay, so I've got 2 more sections, one on temporary post-operative pacing and one on current and future direction in pacing. Any questions?
The previous one was obviously Temp, but that was the initial repair.
Very good. Hopefully there's still people out there. Temporary post-op pacing. The frequency of wire placement has dropped significantly over the last 20 to 30 years around the world. It used to be the case that virtually all patients got temporary epicardial wires, but it's not a zero risk of complications, and so the surgeons are attempting to be really prudent about who they place epicardial wires on, and in the literature it varies between 1.2 and 81% in the last 20 years in different centres. In those that are using temporary pacing wires in 40 to 80% of their cases, they notice that they have some utility of these wires in about a third of them. So in about a third of the patients that they're putting them in, when they're putting them in over half of the time, are finding that they've been useful for either diagnosis of post-operative arrhythmia or management of post-operative arrhythmia, or both. And we know that the major complication risk is something like 0.5%. So that's of death or major re-intervention. And we know some of the risk factors for the requirement of pacing devices. So we know there are some substrates that are more likely to have problems than others, but still you can have substrates that are lower risk that still have problems with arrhythmia post-operatively based on the complications during surgery, such as longer duration of bypass and cross-clamp times, any intraoperative arrhythmia, the requirement for deep hypothermic rest, any severely reduced ejection fraction post-operatively, or any high lactates. And we know that these are the patients, the sicker patients, are going to be the ones that need some potential intervention or investigation of their dysrhythmia post-operatively. And we all know that dysrhythmia post-operatively after congenital heart disease surgery carries with it a reasonably high morbidity and mortality. So what are temporary pacing wires? So we've got the unipolar epicardial leads, and there's some photographs of them there that require the cathode, the negative terminal, to go into the epicardium, and then the anode is placed within the subcutaneous tissue to complete the circuit. And these are thin and small and require less real estate to place on the heart, and so occasionally used by the team when they have no option of the bipolar device. Bipolar have positive and negative terminals placed on the epicardium, usually 8 to 10 millimeters apart, to allow the bipolar circuit to be present and effective. And again, optimization of these is useful because the higher the thresholds, the less time the leads are likely to last for, and the more damage you cause to the tissue underneath due to high output voltages. This will be the box that most people in Alder will be familiar with. You can see that there's an awful lot of potential settings that hopefully you don't play with unless you know what you're trying to achieve and the possible pitfalls of other of the changes getting in the way of the management overall. And so we're attempting to introduce a more defined pacing round on ICU and 1C to ensure that there's any potential pacing issues documented and averted, hopefully. You can see that the diagram shows the two leads of the bipolar system 8 to 10 millimeters apart on the ventricle on the inset, but there's also atrial wires, and that they come down and are tied together with extra loops to prevent them being just pulled accidentally before being placed into the wire that then goes into the pacing box. And the settings of these devices is probably a whole other session. For those that work in Alder Hey, we intend on using this Meditech system on a daily basis now to ensure that there is regular and easily accessible documentation. So there is a piece of paper that flies around by the patient bedside at the minute that's meant to be filled in on a daily basis that cardiology team have probably had less involvement in than I would like. And so we've launched this Meditech form to ensure that on a regular basis we're confirming that we're happy with the temporary pacing systems in place, and hopefully to document any changes so that it's less tempting for people to wander up to the bedside and make some changes and walk away again without anyone being any the wiser, but also to avert any issues such as we've had recently where there was the A wire plugged into the V port and the V wire plugged into the A port, and difficulties gaining the pacing solutions that we needed, and we don't know how long it had been in that configuration for because it wasn't documented. So hopefully this will avoid it. So if you go into documents and new, it's listed as card temp pacing system check. You say who you are and when it is, and then you document that you've confirmed the A and V wires are connected appropriately, that the battery is of a reasonable level, that there is an underlying rate of one rhythm or the other, and that you've checked sensing thresholds and that there's no significant changes or very high outputs. And then you document in the table that pops up the relevant findings. Okay, any questions from the in-house team on those temporary pacing aspects? Yeah. Sorry, Oleg, it's a quiet microphone. Just say that again.
How long could we keep temporary pacing wires?
So temporary pacing wires are designed to not be in position for more than 14 days, but we all know that they can be in place for more than 14 days. And if you get in acceptable parameters on them, there's no reason why you should attempt to exchange them. But you should be fully aware that after 14 days, there's no guarantee that they won't just suddenly stop working. I've never seen that happen. It tends to be a gradual decline in function, but the manufacturer's guidance is 14 days. Does that answer your question, Oleg?
Yeah, and if there is no problem with pacing after surgery, how long would we have?
If there's no problem with pacing, so that will vary. As you can see from the presentation, there was the potential to use pacing wires for investigation and management. So it's okay saying that the patient has conduction and therefore why do you need pacing wires? But there's also the potential for tachyarrhythmia and the need for hemodynamic stability in the presence of tachyarrhythmia. And as you know, that can be sudden onset. So it's about the overall condition, clinical condition of the patient, what the substrate is, and what the plan of the following few days is going to be. So personally, I think leave them in until you're absolutely sure the child's going to be off ICU imminently. If they're still being used or have been used, I would leave them on until there's some stability on the ward, because you really don't want to kick yourself that you've removed them and then need them afterwards. They tend to be reasonably uncomplicated. Any follow-up questions? Good. Okay, so Bernie's wrote a comment on the chat. Those that had sudden death, did they look at the QRS duration, so in the Fallows study? So the point of the comparison of the three groups, Bernie, is that you don't have to look at what the other causes of death were. You were comparing like with like. So yes, there will be some patients in those groups that died because of ventricular tachycardia or ventricular fibrillation. But the point is that they were all Fallows patients, so they all had the same risk of that. And yes, of course, they'll have varying levels of personal risk. That's what makes it so difficult. But they tried to level it up as much as possible. But the idea was to compare groups of those who've had issues with transient complete heart block. And so that's why they tried to keep all the other parameters the same. Okay, any more questions? Very good. Okay, so pacing in this hospital over the last 3 years, we have been able to put in a endocardial biventricular device in a patient with pacing-related cardiomyopathy that made a significant improvement in clinical function. So it was New York Heart Classification 4 and is now 1 or 2, depending on how recently you want to count her recent deterioration. But I was impressed with that. She was 25, 26 kilos when we did that, and you can see the X-ray there. We've not yet removed the epicardial box that came off later on. We've been able to put a micro leadless pacemaker in a 19.9 kilo kiddie. At that point, for about a month and a half, was the smallest in the world to have had a micro device. And there were very good reasons for doing that, with her being a twiddler and a picker, and recurrent infections at the site of her abdominal box, and a real disinclination for putting a box up in the upper thorax where she could pick regularly and then transmit the infection down a transvenous lead into the heart. And so we made a decision to implant a micro device instead, and that's doing really well still. And then we've also planted a defibrillator endocardially in a 19 kilo kiddie this last week. So the smallest one that I've done. I think we've done a slightly small child in Alder Hay before I started here. But again, we're trying to push the boundaries of what we're being regularly asked to do when there's the indication for it. So each of these had good reasons for not following the guidance that I've just given you in the talk. And we'll continue to do so when we need to. And we know that from a surgical side of things that we've done that also. So this is a pacing patient on the left that we've used a biventricular device for, or a dual chamber device for, with the expectation to need a biventricular device in a child with CCTGA that needed long-term pacing and was having congenital heart disease surgery, redo surgery. And so we placed wires prophylactically for biventricular usage. And also we've had a lead fracture of a baby or a child a few years ago. Had an ICD lead fracture for a device that was put in as a neonate in a child in Prague, and then they relocated to Manchester and the lead fractured, and so our surgeons were able to implant a ICD lead to replace the old one. And it's stuff like this that is difficult and is tricky to arrange, but is worthwhile for the patients rather than sending out a region. And I think we should be looking at developing our own in-house ideas about which of these patients we can do more for and which of them can't. And we can do the same sort of thing from the mechanical support side of things too, to try and find the best local solutions for our patients. Thanks everyone for listening. That was 45 minutes, 15 minutes for questions. Hopefully you don't grill me too much.
2 minutes.
You might see this presentation.
Sorry, Oleg, what was that last statement?
Have you finished your presentation?
All finished? You said 45 minutes with 15 minutes for questions. I did 46 minutes. So.
Thank you so much, Mike, for this presentation. I know you're gonna do another presentation in a week's time, isn't it?
I can't wait. Yeah. No, so it was EP in congenital heart disease is the next one I'll do when I'm next on call. I have a clinic on Wednesday, so I'm sorry I'm never in the sessions normally. I have all day clinic instead. So again, lucky me. But
very useful for us. And
it's
have hands-on session probably with external pacemaker box.
Yeah, that'd be nice. When there's a bit more face-to-face action happening, definitely we could have a little bit of messing around with it. And I've got some. If you did want to talk about it, I've got some slides that talk about what sensitivity, threshold, and impedances is. But just wanted to see how everybody felt first. We could always do a troubleshooting thing, but that tends to be a cardiology thing rather than an ICU or a cardiac surgery thing. So thought I'd focus down the slides. Yeah. Good.
Another question, in terms of late recovery, how reliable is this recovery and what time frame is?
Yeah, so that was what I was trying to hint at in the presentation, that actually the time frame for late recovery is really varied. So you really can't rely on there being recovery after day 9. You just shouldn't be waiting for anything after that, in my opinion. There may be other reasons why you delay putting a pacemaker in after that time, but in terms of indication for pacing, even if there's late recovery after day 9, I usually say we should be putting a pacemaker in those patients, because then when there is late recovery, you still don't know whether there's further loss of conduction afterwards. There's still a risk of sudden death, as you could see from that tetralogy of fallow study. So yes, there's limited data, but the data that's there is scary enough for us to go by, put a pacemaker in after day 9, unless there's a really, really good reason not to, regardless of recovery. And the ones that I actually worry about more are, because I just feel fairly confident about the evidence behind that. The ones I worry about more are those where there's recovery of conduction on day 4, 5, 6, or 7, and we decide not to put a pacemaker in. They're the ones that I feel are at increased risk, and we wonder what the right thing to do is. There will be a group of these patients that we could potentially look at putting micro devices in. There's a group of congenital heart disease, but structurally normal heart patients with congenital complete heart block that we could look at putting micros in to avoid epicardial systems. But again, that's kind of where do we go next. But in terms of late recovery, I don't think you can avoid a pacemaker, especially with the class 1 indications that we've got.
Let's say if it's more than 7 days, you would put.
Yeah, I think the Americans are reasonably aggressive and say 7 days plus. I think I've had one patient when I was a registrar where conduction came back on day 8. The rest of them, either it comes back before day 7 or it doesn't come back and it gets to day 9 and we put it in anyway. I think if it's coming back on day 7 or 8, there's a discussion to be had, but usually it's a case of, well, there is an increased risk from day 4 onwards, so I would be erring on the side of putting a device in. But again, that's a conversation between myself and the surgical team and the cardiologist whose patient it is. So again, every patient's different. Just to answer Thomas's question, the Meditech form, yes, it is for PICU. So it's on, if you need a summary of what's going on with the temporary pacing system, it is on Meditech. We're looking at how to have a form that transfers over onto Badger, but the point is that the patient journey will go along on Meditech, and that's where the temporary pacing documentation needs to happen. But PICU shouldn't be filling it in. It should be the cardiology team or the physiology team that's filling it in. Okay. Thanks, everybody.
Thanks.
Mike.